I am Dr. Pooja Arora, mentor just MRCUG. Fetal growth retardation definition. Estimated fetal weight or abdominal circumference below third centile. Second criteria, estimated fetal weight or abdominal circumference below 10 centile with Doppler abnormalities. Same criteria applicable for current pregnancy. One more criteria for current pregnancy when growth crossing 50 centile means when you are comparing two growth scan and the growth is falling 50 centile or more than that. What are the Doppler criteria? Doppler abnormalities means placental dysfunction. If there is any abnormal uterine artery Doppler like PI, mean PI more than 95th centile. Alone having this is not a criteria. With this, one has to have umbilical Doppler abnormalities as well, like mean PI more than 95th centile or absent or a reversal diastolic flow. Most frequently associated with maternal hypertension. In 70% of early onset of FGR, this is the finding, that is maternal hypertension. So important point is alone abnormal uterine artery Doppler is not a criteria. It has to have umbilical criteria as well. Though if there is only umbilical criteria, that is enough to diagnosis any pregnancy as FGR pregnancy in current pregnancy. So I just repeat, Doppler abnormalities, uterine artery and umbilical artery, mean PI more than 95th centile, absent or a reversal and diastolic flow. Growth crossing 50 centile. In this criteria, baby may be more than 10 centile, but when we compare two scan, it is falling 15 centile or more than that. So even if AC or estimated fetal weight, they are giving that it is 15 centile. Do not get confused that it is 15 centile, so it is not FGR. You have to check fall in growth. If it is 50 centile comparing two growth scan, it is a criteria of fetal growth retardation. So absolute criteria is 3 centile. Absolute criteria if it is falling 15 centile, or when there is 10 centile, it has to be associated with Doppler abnormality. I hope I'm clear about this. What are the other parameters? Suboptimal reduced growth velocity, which we have already understood, that is not growing as per protocol. So that is less than 50 centile. Second is static growth. What is static growth? Earlier criteria was when baby is not growing 3 weeks apart. But now it is 14 days criteria, means when you are performing 2 scan at interval of 2 weeks, it is not growing, so it is static growth. What are the criteria in previous pregnancy for FGR? When birth weight below 3 centile or birth weight below 10 centile with placental dysfunction, which we have already understood. And if there is delivery of previous pregnancy before 34 weeks, either in view of early onset preeclampsia or FGR. Here we are mentioning birth weight because baby is already born. But in current pregnancy, we always mention estimated fetal weight. So below 3 centile and below 10 centile with placental dysfunction is same. Types of FGR: early onset when less than 32 weeks, when there is no congenital anomaly, that is compulsory. Then coming to color Doppler or the Doppler abnormalities. If 3 centile, less than 3 centile estimated fetal weight, or if there is absent umbilical diastolic flow, or when AC or estimated fetal weight is less than 10 centile with uterine artery more than 95th centile and having umbilical mean PI more than 95th centile. So if there is uterine, umbilical has to be there. Or if it is only estimated fetal weight less than 10 centile or abdominal circumference less than 10 centile and having only umbilical PI mean more than 95th centile, that is also fine. Late onset, when it is more than 32 and more than that, and congenital anomaly not seen, estimated fetal weight or abdominal circumference is less than 3 centile. So it's same for both early and late. The only difference is the development, at what weeks it develops, right? And the third criteria, when AC or estimated fetal weight is less than 10 centile. That is the first thing, and it can be associated with Dopplers. So there are 3 Doppler abnormalities, or there are some other criteria. 2 out of 3 criteria has to be there. Like first, if estimated fetal weight or abdominal circumference crossing centile more than 2 quartiles for any non-customized growth centiles. Second is when CPR is less than 5th centile or umbilical artery mean PI is more than 95. So one has to have with 10 centile, if the 10 AC or estimated fetal weight is less than 10 centile, so one has to have minimum 2 criteria out of these 3. What is that? Crossing centile more than 2 quartiles, or CPR less than 5, or mean PI for umbilical more than 95. Alone having 10 centile is not enough to diagnose, so one has to have 2 more criteria. I hope I'm clear about early onset and late onset. 32 weeks, more than 32 weeks, no congenital, no congenital, 3 centile, 3 centile. There one more addition, when absent diastolic flow. Then for AC, when there is in 10 centile, there it has to be for early mean PI, uterine and umbilical both. If only umbilical is also more than 95 centile, then it is applicable in case of less than 10 centile. Now, small for gestational age. When fetal size is less than 10 centile at any single point in pregnancy. And how it is assessed? By biometry. Head circumference, abdominal circumference, femur length, or we can combine as estimated fetal weight. Refer to fetus with a predicted weight or an abdominal measurement less than 10 centile. So how we do? Either estimated fetal weight, which is predicted for that particular week, or abdominal circumference, which is predicted for that particular week, and that is falling in less than 10 centile at any single point of the pregnancy. So that is considered as small for gestational age. So what is the difference between FGR and the small for gestational age? Small for gestational age when it is less than 10 centile. But in FGR, if you remember, if it is less than 10 centile, it has to be associated with some Doppler abnormality, either UTI, uterine artery and umbilical both, or umbilical. Small for gestational age baby has normal growth velocity, normal Doppler, normal fetal movement, and normal amniotic fluid. So it is only weight is less than 10 centile or AC is less than 10 centile, whatever is predicted for that particular time. Other than that, growth velocity, Doppler, fetal movement, amniotic fluids, all are normal. Wherein is FGR, other than less than 10 centile, we have to have criteria of placental dysfunction, that is Doppler abnormalities. And the criteria for early and the late are little different. So this is how you have to remember small for gestational age and FGR baby. FGR baby, little difficult, but if you revise, you can remember it. Current pregnancy, previous pregnancy, all criteria you should be knowing, as we have discussed clearly. So I repeat, if it is less than 3 centile, that is absolute. If it is less than 10 centile, it has to be associated with some Doppler abnormalities. Uterine artery alone, if it is mean PI more than 95 centile, that is not enough. There should be some umbilical abnormalities like mean PI more than 95. But if it AC or estimated fetal weight is less than 10 centile and umbilical artery is showing 95th PI, more than 95th centile mean PI, or absent diastolic flow or reversal diastolic flow, that is itself enough criteria to understand that. Now this is the chart. The appropriate growth is between 10 to 19 centile. Anything which is less than 10 centile, that is small for gestational age. Same, anything which is more than 19 centile, that is large for gestational age. So this is how you can easily understand what is small for gestational age baby. I hope I am clear. Now how to distinguish between SGA and FGR? The basic criteria is Doppler velocimetry, that is Doppler finding, or uteroplacental circulation. This is how we differentiate. In SGA, that is absolutely normal, and specifically we measure that in third trimester. What is the criteria in third trimester? That is 28 weeks onwards. That becomes very, very important. So FGR, other than having less than 3 centile, if it is less than 3 centile, absolute criteria. But if it is less than 10 centile, then it has to be associated with some Doppler abnormality. So this is how you differentiate between SGA or FGR in third trimester. I hope I'm clear. We have already discussed this. What is small for gestational? We have already discussed how we identify, right? How we differentiate, and we have already discussed this growth chart as well. And now how to differentiate between SGA and FGR. Now understand one more point. Mostly growth restricted fetuses are small for gestational, or likelihood of FGR is higher in a baby who are small for gestational age. Growth restricted fetuses have evidences of fetal compromise like abnormal Doppler, like a reduced FI. So FI, that is amniotic fluid index. So this is how you differentiate between SGA and FGR. So I hope I'm clear about how to differentiate between SGA and FGR. Now we are going to discuss what all factors, risk factors, which are responsible for SGA or FGR, or when you take any history. Okay, one more thing, static growth, which we have already discussed, that 14 days apart, if we are taking 2 scan and there is no forward growth velocity, it means there is no fall as well. We have read one more criteria, that is falling 50 centile. That is not static growth, that is fall. Static growth means there is no forward growth velocity in estimated fetal weight or abdominal circumference when we measure at 14 days apart. So fetal growth assessment, one has to have 2 assessment. That's common sense, right? And we also include additional information like maternal history, like symptoms, like AFI, like Doppler velocimetry. So this is how we differentiate static growth or FGR. So understand between two. So in FGR, we also take certain parameters, right? As we have discussed, when there is reduced growth, so that is falling 50 centile or more than that. Static growth, when there is no forward growth and interval is around 2 weeks. So I hope now I'm clear about early onset and the late onset. Now, what are the risk factors? Risk factors we can see at different level, like at booking, including maternal condition. When she is progressing, then what are the antenatal risk factor and any risk factor which is developing in pregnancy and the current pregnancy. So this is how we are going to take care of all risk factors. You have to make sure that you have to assess patient by 14 weeks for any risk factor. And the criteria would be, if there is any previous pregnancy, then what was the birth weight, at what time she delivered, and what was the birth centile. And we have to record this at booking itself. Then we are going to make a customized care plan that we are going to combine risk factor, and we should inform patient that on the basis of that we are going to offer her targeted scan like uterine artery Doppler and umbilical artery Doppler or only umbilical artery Doppler. Now risk factors. So as we have already mentioned at what level we are going to think about risk factors. So very first is at booking. If there is previous FGR or SGA, previous stillbirth, previous preterm, previous pregnancy loss, previous pregnancy placenta mediated complication, and next is medical condition, diabetes, moderate and severe renal immunopathy with hypertension, antiphospholipid, chronic hypertension, SLE, complex congenital heart diseases, ventricular dysfunction, NYHA class 3, class 4, anticoagulant use, beta blocker, all kind of LOLs, maternal age 40 or more, BMI if it is less than 10, poor weight gain in pregnancy. Now, what are the risk factor in antenatal period? Alcohol, 1 drink per day or doubling the risk with 4 drinks per day. So if somebody takes 4 drinks per day, it will double the risk whoever is taking only 1 drink per day. Drinking 32 grams per week or less, that is 2 UK units up to twice per week. 2 UK unit up to twice per week. That is the evidence which shows that it is less risky, though it is always suggested that there should be alcohol free and the smoking free environment. And there is also given by the smoking. For smoking, if somebody is taking smoking till 15 weeks and she stops after that, it is going to be as good as a non-smoker. So somebody comes at 15 weeks that she is smoking, you can reassure her. Drugs, again, this increases the risk of FGR. BMI less than 18, having eating disorder, bariatric surgery, especially gastric bypass because it causes malabsorption. We offer ultrasound, series of ultrasound, okay? Then caffeine, certain ethnicity, these are all responsible for FGR. Now caffeine, maximum 200 milligram per day. That is 2 mugs of instant coffee. 300 milligram or more associated with SGA, especially if taken in last trimester of pregnancy. So these are the risk factors. Now we'll talk about any risk factor which is in current pregnancy and if there is any marker.